Perfect. So we'll go ahead and get started. As I mentioned, I saw some few people already putting introductions into the chat, which I absolutely love. Please, if you haven't, do go ahead and add yours. But we will start with a couple of introductions and announcements. Dr. Chastain will be presenting today on when genotype and fibrosis matters in adults. And then we will end with a couple of case presentations and closing remarks. A quick reminder, please make sure that you are registered for this particular session through Southeast Age Education and Training Center. This will play a role in your continuing education credit and availability, but also Southeast Age Education and Training Center provides a lot of additional resources as well. And so please check that out. We will make sure to add the link into the chat so that you can take just a moment while we are all here together and get registered. I believe I was able to add it into the chat. So I'm going to pause for a second while individuals take a moment to please go ahead and register so that we can make sure that, and if you've already registered, it's a really quick process. You just kind of log in and then you will see, you can look at the calendar in the session and be able to make sure that you're registered. Click the registration button and that's pretty much it. So pretty straightforward to make sure that you have access to all the resources and your continuing education credits at the end as well. Feel free to give a thumbs up or let me know that you have been able to access it okay. And I see a few more introductions in the chat. Yes, happy pre-4th of July. And great to see some friends from South Carolina. Awesome. Let us know if you have any questions with this. We will go ahead and continue on. Nearly everybody has already put their information for introductions in the chat. So fantastic. I see names and roles. Let us know if this is your first session. We're always excited to hear about that and welcome new folks. And it is 4th of July. So if you have anything super exciting for 4th, we're always happy to hear about it too, or what your favorite activity is. So let us know. With that, we will go ahead and switch over to our didactic. So I'm gonna turn it over to Dr. Chastain to get us started with when hepatitis C genotyping and fibrosis matters in adults. Dr. Chastain?
Thanks, Mia, and appreciate everybody being online today. And we'll go ahead and get started. We can move to the next slide. So I don't have any financial disclosures or conflicts of interest report. Move to the next slide. So I want to encourage some interactivity today. I know that we have some technical challenges, but also we have some opportunities to facilitate some conversations around this. And so to make sure that I'm meeting your needs, I would love for anybody who's attending, if you have burning questions about hepatitis C genotypes and or liver fibrosis as it might pertain to hepatitis C, go ahead and enter them into the chat box right now. This will allow me to integrate that into what I'm going to present. And also we can talk about it intermittently as we move through. What I'm going to do during this section is present some information to you about genotypes and fibrosis. And then I'm going to go through a few cases to illustrate that. So if there are no questions, great. But I want to give you an opportunity to ask about hepatitis C genotypes as well as liver fibrosis. And I'll try to integrate that because a lot of what I'm going to talk about today is, does it matter as it pertains to hepatitis C treatment? But you might have broader questions about these topics as well. I'm happy to address those. We can move to the next slide. So by the end of this brief didactic, these are the 3 things I hope that you'll be able to do. I hope you will identify at least one scenario when hepatitis C genotype can affect prognosis, treatment, and or management. And I hope you can identify at least one scenario when liver fibrosis can affect hepatitis C prognosis, treatment, or management. Ultimately, I'm also going to highlight how you can apply HCV guidelines and specifically resources to help assist your clinical care. Next slide. So these are the questions, at least in my mind. They might not be the questions you're going to put in the chat box because I'm still looking for those. But in my mind, as it pertains to this didactic, does it matter? Well, if it matters or not, it probably boils down to one of these three things. How does HCV genotype impact prognosis, how well someone's going to do, the treatment, what treatment we select or use, or the management overall of a person with hepatitis C? Does the genotype affect any of those things? If it does, it probably matters. If it doesn't, probably doesn't matter. Similarly, how does liver fibrosis impact prognosis, treatment, as well as management? So these are the fundamental questions. What I'm going to do is I'm going to go through HCV genotype, hitting prognosis, treatment, and management. And then we're going to come back to liver fibrosis, talk about prognosis, treatment, management. Next slide. All right, let's talk about prognosis. There's a lot of history to hepatitis C as far as hepatitis C being considered non-A, non-B hepatitis, and then hepatitis C considered one entity, and then different genotypes that really have markedly different outcomes with different conditions. In historical data, like we're talking about 90s and early 2000s, is that genotype 1 was considered the worst, quote unquote, for prognosis purpose. And that was really linked not to how the genotype of the hepatitis C impacted any biology, but rather genotype 1 was the most difficult to cure with interferon, pegylated interferon, and pegylated interferon and ribavirin combination therapies. And since cure was less likely with genotype 1, patients with genotype 1 generally did worse than patients with genotype 2, 3, 4, others that generally had a better treatment outcome. If you flash forward, or if you focus just on liver biology, there's been suggestion that genotype 3 might actually be the worst. And that's because genotype 3 has been associated with increased risk of fibrosis and increased risk of steatosis or fat tissue deposition within the liver. But I'll honestly say today, when people ask me about, well, does hepatitis C genotype impact how well someone's going to do? I would say it's pretty marginal today. Because today, with direct-acting antiviral therapies, they all have high efficacy. The cure rates for all genotypes is incredibly high. And so overall, if a person has access to care and access to treatments, genotype doesn't make a big difference in prognosis as far as how well someone's going to do. Next slide, please. Well, then the next piece is like, well, how does hepatitis C genotype impact treatment and or management? Particularly in an era when pangenotypic regimens are available. And for those who are new to the call, pangenotypic simply means that a treatment works for all different genotypes or genetic types of hepatitis C. So if we have pangenotypic regimens available and those are used as part of our simplified guidance for the most commonly used medications, does genotype matter when it comes to treatment and management? And not a lot. Where does it matter? I'll give you 3 scenarios. One is prior authorization, is that, quite frankly, a lot of insurance or pharmacy benefits require prior authorization for hepatitis C medicines, and they're often expensive. And because of that, they often collect different pieces of information, and genotype is often a required element of prior authorizations. So genotype might matter there. Genotype may matter if you're going to use an alternative hepatitis C regimen, not a first-line regimen or one in the simplified guidance. And I'm going to come back to that with an example case. The other piece is to recognize that genotype as a standalone item may not be an issue, but when you consider genotype and someone's fibrosis status together, those two together might impact how we select treatment. And I'm going to bring up a case to illustrate that as well. All right, we can move to the next slide, and I'm going to pivot from genotype to fibrosis. So let's just start off with the obvious, is that fibrosis is intricately linked to prognosis because that's one of the key outcomes that we talk about with hepatitis C. One of the reasons we care about hepatitis C is the potential that it could lead to liver fibrosis. When liver fibrosis is severe, we call that cirrhosis. When people develop cirrhosis to the point that their liver cannot adequately function, we call that decompensated cirrhosis or decompensated liver failure. And then ultimately, that is part and parcel of prognosis. So fibrosis is linked to those things. We do recognize that hepatitis C treatment reduces the likelihood of someone progressing or their fibrosis worsening. We also recognize that treatment can reduce the complications of decompensated cirrhosis or liver cancer. So treatment is important to prevent fibrosis from progressing or ultimately leading to the downstream. And so if we interact with a person who has got no scar tissue or no fibrosis, or a person who already has severe fibrosis, that can impact how well that person is going to do. It's only natural to recognize that person who already has severe liver disease by the time that they meet you at your clinic have a worse long-term outcome than someone who meets you who has hepatitis C but has no permanent damage or permanent scar tissue at this point. So we can move to the next slide. Now, I have seen the chat box questions, so I'm coming to it. Let's talk about fibrosis and treatment. Fibrosis can impact selection of hepatitis C therapies. And those of you who have been along for this ride since 2014 with the early direct-acting antivirals that first ushered out interferon recognize that we used to talk about fibrosis and staging a lot to determine which therapies we could use. Sometimes we could use certain therapies if someone did not have cirrhosis, and other therapies we couldn't use if someone did have cirrhosis. But I'll be honest, today is that it can impact when you interact with the genotype, which again, I mentioned before, or if someone already has severe liver failure. That's the one place where the degree of fibrosis directly impacts the safety of treatment, because certain medicines require the liver to be functioning to be adequately metabolize medications. I'll also note that if someone has so much fibrosis to the point that they're being considered for a liver transplant, whether that because of liver failure or if they've got liver cancer, there are times where that might impact our decision to treat, because sometimes we do not treat people when they're going to receive a liver transplant because they might receive a liver transplant organ that has been is from a hepatitis C positive donor. And so treating someone after transplant might actually make more sense than treating before transplant and after transplant. So fibrosis today doesn't make as much of an impact on treatment, but it can. Let's finish up with one more information slide before I move to some questions. Next slide, please. So fibrosis and management, this is kind of writ large. This is writ larger than just hepatitis C treatment. I think it's important for us always to remember that if someone has advanced fibrosis, F3 or F4 fibrosis on the Medivir scoring system, those patients may still benefit from ongoing liver care. So per the WSLD HCV simplified HCV treatment algorithm, for people with compensated cirrhosis, you can see the box to the right, those patients, even after they are cured of hepatitis C, still warrant ongoing hepatocellular carcinoma screening with an ultrasound every 6 months, with or without an alpha-fetoprotein blood test. And they also would potentially benefit from upper endoscopic surveillance for esophageal varices. So it's important to highlight that fibrosis can impact our management, not only in treatment selection, but in longer-term care for people. Next slide. So I intentionally put kind of a pause here for questions. Got one question here in the chat box, but I welcome others. Could genotype matter when trying to determine if a patient failed treatment or was reinfected? Okay, it's a great question. This is one that comes up at times. What if you had a person who had a genotype and they were genotype 2, were treated with hepatitis C therapy, had an established sustained virologic response, were released from care, and then 2 years later came back into care and were found to have hepatitis C again, and we had an interval risk factor, and a genotype was checked, and it was a different genotype, genotype 3 or genotype 1. That would be conclusive evidence of reinfection. So a genotype could be quite helpful in distinguishing that case, although the reality is probably isn't going to have a big impact on whether or not we're going to treat or what we're going to treat with. In that type of scenario, even if I didn't have genotype data before and after, I would have had conclusive evidence that the person was cured if they had gotten that follow-up blood testing. And if they had an interval risk factor, I could probably presume that they had a new infection. I'll give you a different scenario. A person is on treatment for hepatitis C therapy and checks in with you at their week 4 appointment, doing great, and they've got 4 more weeks to go. But then they never come back to clinic. They never come back to end of treatment. You can't connect with them by phone. They never come back for sustained virologic response testing. And a year later, they come back into clinic and hepatitis C is still detectable. You don't have a genotype before treatment. You don't have genotype after treatment. Well, honestly, in that scenario, you probably are going to presume that that person failed treatment, although it's possible they could have been reinfected. So the other collateral information is also helpful, but I would admit that if you had genotype data before or and after, that's often helpful. But I've also had scenarios where I had the same genotype the first time and the second time, but I had lots of other evidence pointing towards a new infection. And of course, since there's only a handful of genotypes, it's very possible that people can be reinfected with the same genotype. So ultimately, it's one piece of information to weigh, but it's not the only piece of information to weigh. Another question that came in from Janetta. So if a patient has successful treatment for hepatitis C and no fibrosis noted, is the ultrasound alpha fetoprotein still recommended every 6 months? That's a great point, Janetta. And the answer conclusively is no. If a person has limited fibrosis or no fibrosis at the time that they start hepatitis C treatment, the simplified guidance for people without cirrhosis essentially states that those people, after confirmation of sustained virologic response, do not need any further liver-specific care or monitoring. Now, if a person has other health issues that impact their liver, that might be relevant, but it's not necessary to continue following those patients in the same way. That is why it's so critical to actually get upfront staging information that you trust, using things like AST to platelet ratio index, using things like FIB4 indices, FiberSure assays if you're using proprietary lab tests, things like transient elastography or other tools, because that pre-treatment staging is very, very helpful to interpreting what we should do after. And Mia has helped by sharing some additional data and links there in the chat. Dana also noted in the chat, I've seen patients with 2 different genotypes at the same time. Does that affect how they are treated? This is a rare, but it is a recognized entity where patients can be infected with more than one genotype. And ultimately, this was a real challenge in the era before pangenotypic regimens. But today, typically a pangenotypic regimen can be utilized with minimal additional changes. If you had a patient with genotype 1 and genotype 2, ultimately the recommendations for treatment with simplified guidance would be the same, regardless. Historically, this could have been a big difference because there was an era of time where certain medicines only were effective for certain genotypes. And so that might have relevance in certain situations. But generally speaking, if you're choosing a pangenotypic regimen, that's not the case. Great questions. I'm going to take an echo pause here, see if people want to come off mute and ask a verbal question.
Can I ask a question that's a little bit unrelated?
Yes, Brenda.
I have a patient that I just recently tested, never been treated for Hep C, but was diagnosed a few years ago. And her viral load is like 75. Does that often relate to genotypes? And I'm assuming that's someone we would still treat because she's had it for a number of years and is an IV drug user.
Great question, Dorinda, and a question that does come up at different points. So I'm so glad that you asked it here for everybody else to benefit from as well. Point 1, very high viral loads can be associated with increased risk of fibrosis over time. We generally don't think, though, that the height of a viral load is nearly as important as whether it's qualitatively positive or negative. So generally speaking, if someone's positive or negative, that's all that really matters. Sometimes patients come in, they talk with me, and they're really worried because they perceive that their viral load is really high, and ultimately the height of the viral load actually does not contribute that much to the likelihood of future fibrosis. But technically, if you had a person with a viral load of 25 million and a person with a viral load of 75, generally speaking, if you watch those two populations for 30 years, the people with a higher viral load generally have more complications. Ultimately, it doesn't change anything that we do, though, because we do recognize that there are patients with low viral loads that still have clinically significant outcomes. So we do treat all people. There are 2 caveats that come with this. One is to recognize that if you have a viral load less than 1,000, it may be difficult to get a genotype effectively conducted on that test result. In fact, most of the time the lab will not run it. And that often means that prior authorization will not be approved without an appeal letter that just simply states that the viral load was too low to obtain a genotype. And I've never had an appeal that's been rejected on the basis of not having a genotype because I couldn't get one because of viral load. And if you ever run into a situation like that and you want an appeal letter template for that issue, our clinic does have that. So you can contact us through the ECHO website and through the email, and then we can connect you with the resources. The second thing I want to highlight is that patients who have been recently infected, not your patient based on what you described, but a person who may have had an exposure within the last 6 months and may have been infected within the last 6 months, people with acute hepatitis C can have drastic fluctuations in their viral load. It can go super high to super low to super high to not detected to back elevated again over that 6-month window. And so I tell people, if you're convinced that a person was recently infected and their viral load is that low, it may be reasonable to recheck their labs in a few weeks or months to see if they've actually spontaneously cleared the infection. On the other hand, it is now recommended to treat everyone who's acute or chronically infected. So I wouldn't delay therapy dramatically in any patients. But if you have such a low viral load that you think that they might be clearing it without treatment, it's also very reasonable to reassess. However, in a person who's had risk factors greater than 6 months, or who I've had documentation that's greater than 6 months, then I don't bother repeating tests. I just go ahead and move forward. It's a great question.
Corresponding to that, or clarification on that, how long does it take for the antibody test? Like you're talking about the acute hepatitis, how long does it take for the antibody test to test positive?
It's a great question. And I would say the majority of people that I detect acute hepatitis in, both the antibodies positive and the RNA is positive by the time we assess the patient, which can be within days to weeks. It can take up to 3 to 6 months for a hepatitis C antibody to become positive. So there is a window period, but the vast majority of patients, well over 95% of patients, already have a positive antibody within a few weeks.
Okay, because I have a second patient that just suddenly had a dramatic increase spike in LFTs after going on a IV drug use binge. And hepatitis panel came back negative. So I was just wondering the time frame to repeat, but I'll recheck that in 6 months.
I would say that's a great point. And I would say that this is, if you have a clinical suspicion for acute hepatitis, I think the learning point here, and it's a great one that you brought, Dorinda, is that if you suspect acute hepatitis based on history, exam, or laboratory studies, the appropriate way to test for hep C is both an antibody and an RNA test if you suspect clinical acute hepatitis, because while an antibody usually turns positive, there are definitely cases where I've seen an RNA positive and antibody negative in a person with clinical disease, like what you described. Great questions and clarifications. Another question came in from Olivia, and she is going to narrative side. I took a patient with HIV and hepatitis C co-infection after starting antiretroviral therapy, and the patient now has had liver function tests that became quite elevated. Abdominal CT is negative for cirrhosis or hepatocellular carcinoma. The fibrosis scoring is quite high, likely erroneously, which what she's referring to is that if you use some of these scoring systems for patients with acute inflammation, you can predict advanced fibrosis, but it actually might be an over prediction because acute inflammation can alter those results. Will it be beneficial to recheck the FibroSure when checking for SVR after treatment in order to determine need for LGN alpha protein? A couple things to highlight. Olivia brought up a great example of immune reconstitution inflammatory syndrome. The idea that as someone rebuilds their immune system, either after chemotherapy or after a stem cell transplant, or upon starting treatment for HIV with a rebound in their immune system, that sometimes the immune system can attack where the virus is, and the liver can become inflamed, just like we think about with acute hepatitis. So this is a phenomenon that is recognized and described. What is a highlight here is that non-invasive testing, AST to platelet ratio index, FIB4 scores, or FibroSures, even transit elastography are often not accurate in the setting of acute inflammation, because acute inflammation can falsely change the results of those tests. So in that setting, what we have to do is do the best we can, which is to assess their fibrosis effectively after treatment. Ultimately, we don't want the perfect to be enemy of the good, and the best thing for this person is to treat their hepatitis C as quickly as possible, because that can diminish any inflammation or damage that's occurring. But that does complicate how best to get that information to predict scar tissue after treatment. Generally speaking, AST to platelet ratio indices and FIB4 indices and even fiber share indices are not very accurate post-treatment. That's why doing it before treatment is really important to recognize what data you're putting into those systems. The one test that can be quite helpful post-treatment is transient elastography, because a transient elastography test that is completely normal post-treatment is typically consistent with no significant scar tissue. So, Olivia, we can talk about resources about this offline or in follow-up, but I would say in a patient like this, I would not allow the uncertainty about that person's fibrosis to keep me from treating them. I would move forward to treat them, but recognize that I don't have a clear-cut answer about how long they need to be monitored until after I get things squared away. Mia also shared some great links from the National HIV curriculum, National Hepatitis C curriculum, which I encourage anyone to look at as far as resources that can highlight some of these different changes. Let's move to the next slide, because I've got a couple cases to illustrate just some quick points before we move into our actual real cases. Next slide. Our 4 cases, I'm just going to compare and contrast very quickly. Case 1 and 2. Sam is a 23-year-old woman with opioid use disorder, including injection drug use. She has genotype 1A, hepatitis C RNA that's 2,300 copies per cubic milliliter. She has an AST to platelet ratio index less than 1, and a FIB4 index that's less than 3.25. She's treatment naive. Ben is a 55-year-old man originally from Vietnam, recently screened and found to have hepatitis C. He's got genotype 6. He has a moderately elevated viral load. He has a high AST to platelet ratio index and FIB4 index, both concerning for advanced fibrosis. He's treatment naive, and the ultrasound is consistent with cirrhosis without evidence of liver cancer. We can move to the next slide, and time notwithstanding, I'm probably going to move forward. How do they differ regarding hepatitis C? And the differences are obvious, right? Age, gender, genotype, degree of fibrosis. Those are the obvious things that are different. Even the viral loads are different. But if we can move to the next slide, just going to highlight here is that both of these patients can be treated with simplified hepatitis C treatment for treatment-naive patients. You just would pick a different tool, one for Sam without cirrhosis and one for Ben with cirrhosis. We move to the next slide. Their initial evaluation would be very similar, with the exception of the ultrasound evaluation for hepatocellular carcinoma screening for Ben and a couple other additional lab tests. Both can be treated with glycapeptide per parentosphere for 8 weeks and sofosbuvir velpatasvir for 12 weeks. The management really is only going to differ for these 2 patients post-SVR. Both of them have got a great prognosis from a hepatitis C standpoint, both with genotype 1 and genotype 6. But Ben already has advanced fibrosis, so warrants additional monitoring to prevent other liver complications. We move to the next slide, though. I'm going to highlight some of those things I mentioned before. So let's do case 3. So case 3 is actually case 1, but we'll do some movie references here. And so that we just changed a few minor details. So Sam's the same 23-year-old person, but Sam has an insurance that prefers ledipasvir sofosbuvir, not sofosbuvir velpatasvir, not glycapeptide per parentosphere. But Sam also prefers the shortest course therapy possible. She really wanted to take an 8-week course of therapies. Let's move to that next slide. So what could you do? Well, you could look at simplified guidance, but since you have some other complexity in this case, I just want to highlight how to use the guidelines beyond just those PDF documents. Next slide, we'll just show you an arrow that's going to come in. You can hover over the treatment naive, next section, or next slide, sorry. After you hover over that, you can hover over genotype 1. And if we move to the next slide, by hovering over genotype 1, you can pick a selection that best fits your patient. And you can do this for any of the genotypes that are listed or the different settings. By clicking on that, you go to the next slide, there's actually a summary of the different regimens that are recommended versus alternative. And then there's a whole narrative down below about why. So you can see that for Sam, there's actually more than just sofosbuvir velpatasvir for 12 weeks or glycapeptide per parentosphere for 8 weeks recommended. That's what's in the simplified guidance. But since you know genotype in this case, you can also highlight that she is also eligible for ledipsir sofosbuvir for 8 weeks or 12 weeks, depending on HIV status and her hepatitis C viral load. So just as a highlight, we don't have to just use those simplified guidance. There's actually a lot more information in the hcvguidelines.org that you can use. Let's move to the next slide. If Sam had cirrhosis, you would have hovered over genotype 1A with cirrhosis. And what you notice here is that there actually isn't an 8-week arm of ledipsir sofosbuvir recommended for people with cirrhosis. So if ledipsir sofosbuvir was requested by their insurance or provider, you could navigate that accordingly. Let's move on to the next slide, which I think will bring us in the multiverse to Ben. So this is case 4, but his alter ego in another timeline. Instead of having genotype 6, he has genotype 3. Everything else is the same. And you routinely use the simplified guidance to assist in your care for patients. You usually sofosbuvir velpatasvir for 12 weeks based on your payer mix, your patient support programs, and your prior experience. But I do want to highlight, we move to the next slide. This is really, really important. This next slide highlights the simplified guidance with cirrhosis. And the simplified guidance for with or without cirrhosis, the treatment is the same for everyone, genotypes 1, 2, 4, 5, and 6, whether people have cirrhosis or whether people don't have cirrhosis. And it's even the same for people with genotype 3 if you're going to choose glycopropensivir. The only difference is if you have a person with genotype 3 and they have cirrhosis, and you're going to use sofosbuvir velpatasvir, there is this note in here that those patients may be at higher risk to harbor an NS5A resistance mutation. And if a patient has a Y93H mutation, they may have a lower likelihood of cure. And to be cut to the chase, if you're going to treat them with sofosbuvir velpatasvir, it's recommended to add ribavirin in that context. What's really important is to recognize, who do you care for in your population? Do you check genotypes? Do you care for people with cirrhosis and without cirrhosis? If you don't check genotypes, and if you routinely use sofosbuvir velpatasvir in your clinic, and you take care of people with cirrhosis, it's important for you to recognize that if you don't check genotypes, there might be a very small percentage of your patients who are genotype 3, and of those, a portion that have cirrhosis, and of those, some that might not have as high of a cure rate. Now, that's a lot of coulds and shoulds and maybes. Genotype 3 is about 10 to 15% of the US population of hepatitis C. Of those, some, probably 10 to 20%, have cirrhosis. And the cure rate of having an NS5A mutation, only about 10% of people with genotype 3 have that mutation. And if you accidentally treat somebody with that mutation with sofosbuvir velpatasvir alone for 12 weeks, their cure rate is still 70, 80, 90%, depending on what study you look at. So ultimately, while this is important, I want to highlight to you that you would probably have to treat 1,000 people without checking a genotype to happen across that person with genotype 3 with cirrhosis who has the mutation. So realistically, this may not impact your practice pattern, but I do think it's important to highlight this in the simplified guidance, because only you know how you're practicing in your setting about what genotypes you check, whether you check them, whether you don't, what's going on. All right, next slide. We're wrapping this thing up. Hep C genotype and liver fibrosis are important to prognosis, treatment, and management. However, genotype and liver fibrosis have less and less impact on routine clinical care in most settings and cases. Utilize hcvguidelines.com to assist in treatment and management, and also your friends at ECHO, as well as myself, the SEATC. With that, we'll move to the next slide. We'll share our ECHO email and pause again for questions. Rajiv.
Cody, I have a question related to especially people who may have acquired hepatitis. So they're immigrants, they've traveled to the United States, and also the population among the people who inject drugs who may be sharing needles, about testing of partners or family members where they may have either through sharing of needles or the environment where they're in. I just